this webinar. I see 56 participants. Maybe more will join when we start. So we should start now. Let me just introduce and start off, and then I will hand over to Paul, who will be the speaker today. So this webinar is one amongst a number of webinars that Stop TB Partnership, along with the ETTI, End TB Transmission Initiative, which is a working group of the Stop TB Partnership dealing with infection control, will be organizing. So it's a series, and we plan to do it every Tuesday, and more will come. Some of you may or may not have been in the last week's webinar, which was quite interesting, quite heavily attended, I must say, and we went half an hour beyond the time allotted. Today we have less than what we had, much less than what people connected, much less than what we had last week, but hopefully it will grow. So I am Suvanand Sahu. I work in the Stop TB Partnership as the Deputy Executive Director. I will now hand over to Paul Jensen from ETTI. We also have Carrie Tudor from ETTI on this call, and Paul will be our main presenter here. And we will, it's a long webinar, about 1.5 hours, but Paul will do it in two phases, and we will have an interaction with people in between, and also at the end, you can also send questions. You can also keep sending your questions on chat if you want, and we can pull them out and discuss them as well. So, Paul, over to you.
Thank you very much. And Carrie, would you like to say a word or two about ETTI?
Yes, that'll be very good.
Good morning, good afternoon. Thank you, Paul, and thank you again, Sahu, and to Stop TB for allowing us to do these webinars. So the NTB Transmission Initiative is a working group of the Stop TB Partnership, and we're focused on airborne infection control, mostly for TB, obviously, but recognizing that COVID has an airborne component, and the infection control measures for TB are also relevant for other airborne infections. And so we're made up of a group of experts in infection control. I think at the end of Paul's presentation, he has some materials that we've developed that are available on the Stop TB website. And as Sahu said, this is the second in a series of infection control workshops that or presentations that we're doing. And so we hope to see you at the future workshops. And I don't want to take up too much time, so hand it back to you, Paul.
Okay, thank you, Carrie. And can everybody see this title slide? Okay, so again, this is just an introduction to airborne infection prevention and control, and just need people to remember it's more than just TB. And I'm just going to go through a few references very quickly. WHO in 2014 updated their document about acute respiratory infections, which is a very good guideline. 2016, they came out with guidelines for the core components of infection prevention and control, which deals mainly with catheter-related infections, but it also deals with a lot of other contact precautions, as well as a tiny bit of airborne. And then just last year, they came out with another document that supplements the 2016 document, which talks about minimum requirements. It gives a little more of the how-to detail. I would be remiss if I didn't mention the 2019 update for the WHO guidelines for TB. CDC has a document also, which is unfortunately very large with too many words, but there was a minor update in 2019, so that's another resource for you. And both the WHO website and the CDC website have fabulous information on the COVID-19 as well as other stuff. Let's start with a nurse. Florence Nightingale is well known as being a person who always thought about infection prevention and control. And this is one of the famous quotes from her, is that it may seem a strange principle to enunciate as a very first requirement of a hospital is that it should do no harm to the sick. And we could substitute other words for hospital. We just basically want to make sure that we stop transmission of any airborne disease. And that transmission could be from patient to worker, to patient, another patient, to a visitor, to a family member. It could be from a worker. And notice I'm not just saying healthcare worker. It could be a worker to another worker, patient, visitor, or family. It could be from one of the visitors to a worker, patient, visitor, or family. Lastly, it could be a family member that brings in some type of disease which is transmitted within a facility. So what is airborne infection prevention and control? And I'll be using this abbreviation IPC for infection prevention and control. It's really part of the general infection prevention and control program. Quite often with TB, you'll hear people talk about, oh, you have to have a TB infection prevention and control program. Well, that's true, but it should be part of the overall infection control program. So let's talk about the general infection prevention and control. First, everybody's heard of standard precautions, formerly known as universal precautions, which was mainly for bloodborne pathogens. And what we're seeing now is we need standard precautions for coronavirus. And when we talk about infection prevention and control precautions, they're based on different transmission methods or modes. There's contact, where if I, let's say, sneeze into my hand, then I touch my phone, and then somebody else borrows my phone, what have I done? Because of the contact or touching of different surfaces, I've transmitted coronavirus, rhinovirus, could be anything. Then we're talking about large droplets, like while I'm talking, there's some large droplets probably coming out and landing on my computer. They won't go very far, and that's why for coronavirus initially, people talked about whether you're talking about WHO guidelines or CDC guidelines, 1 to 2 meters distance. And then lastly, we have the airborne transmitted diseases. Those are small particles. You may hear the term droplet nuclei, you may hear the term micro droplets, but they're the very small droplets that will stay airborne for a long period of time. So how do we reduce risk? Well, we have risk in the facility, you may have risk in the lab, you may have environmental controls, you may have policies for staff. In this case, this is a tour of facility, but everybody's wearing a gown, everybody's wearing a respirator. We did not have to worry about contact or droplet precautions, so we only dealt with respiratory or airborne precautions. And what's this guy doing in the corner here? He's not playing video games. He's looking at the surveillance data both of patients in his facility and of staff. So how do we reduce risk? How about flying in an airplane? Is that risky? Well, it may be. You know, if you have a new pilot, you know, yeah, I'd be a little concerned. If they're not doing proper maintenance, I'd be a little concerned. But what about jumping out of an airplane? How many people have jumped out of an airplane? I have never, and I don't plan on ever doing it. But let's take a look at this short video. These guys are going to parachute out of the airplane. This one guy's super excited, and there he goes. This next guy, well, he's not quite so excited. What's this? Piva, Bud Light beer. Oh, this guy wants the beer. What happened? It's not over yet. Now it's over. So what happened to the risk with that guy? It changed over time. There's risk of the airplane, then there's risk of parachuting, and now he's what? He's standing in an airplane with a parachute on his back and nobody else there. So whether you're going from location to location, process to process, risk is not constant. And here's an example. This is a study by Dick Menzies' group where they did analysis of the literature, and they found that in outpatient facilities, the incidence rate ratio relative to the general population was all greater than 1. For outpatient facilities, it was 4 to almost 12. The interesting thing is emergency departments. That's 26 to 31. Why is it so high? Because in a lot of those places, people may come in with a broken arm, but they also have TB. They may come in with something else, but have TB. So it's the undiagnosed patient. And for inpatient facilities, where do TB or other patients go initially? You may have a COVID patient sitting next to a TB patient, next to a diabetes patient, but that TB and coronavirus patient has not been diagnosed yet. But as soon as they're diagnosed, then they go into isolation. So we have to think about what do we do with presumptive patients with different respiratory diseases. So I'm going to talk about the hierarchy of infection prevention control. We generally think about administrative controls to reduce the risk through policies and practices. Environmental controls, we think about reducing the concentration of the bioaerosols in areas where contamination of the air is likely. And then personal protective equipment, or PPE, really protects the personnel when all the other measures are not enough to reduce the risk to an acceptable level. What I want to show you here is a slightly different hierarchy. It's still on the left-hand side as administrative controls, environmental controls, and personal protective equipment. But you may be using a slightly different type of control for the worker, for the patient, or for the entire facility. So what kinds of administrative controls would you have for the worker? Well, you might have an infection prevention control plan. So you'd have a written plan. This is not everything that's in the plan, but here are some things that are highlighted. You want to make sure in the plan you have the fundamental principles of infection prevention control. Have the guidance or the tool for doing an infection prevention control assessment of the facility. What needs to be in your training and education programs? How about surveillance or tracking of disease in the facility, not just the staff, medical staff, but all the staff, all the people that go through the facility. Need to make sure people understand standard precautions, transmission-based precautions, performance improvement. What happens in emergency? Most places were not prepared for the COVID-19 pandemic. So I'm hoping that most of them, once they get a chance to breathe or relax, come back and revise their infection prevention control plans to deal with this type of an issue, and then always evaluation. How about surveillance of the staff? In this case, it's an x-ray of a patient/staff member that has TB. Training, it's training all folks from different positions in the facility, not just the people who meet and greet, not just healthcare workers. We need to make sure that people in the facility understand infection prevention and control measures. Not everybody needs the same message, but they all need at least some type of messaging. How about for the patient? Cough etiquette. We want the patient to follow proper cough etiquette, but we also want the worker to follow proper cough etiquette, and everybody in the facility. But here's a waiting area of a facility. Do you think they're following good cough etiquette? Well, a lot of them are. This guy is not, but a lot of people have some type of covering over their mouths and face. This is a very open area, so from the standpoint of natural ventilation, it's very good. How about this? This is a pediatric ward in a hospital in South Africa. Do you think it's crowded? What do you think would happen during the COVID-19 pandemic here? You know, is this appropriate spacing? Is it appropriate personal protection? Appropriate PPE? Well, these are things when you do your facility assessment, you take a look at, you know, and say, okay, in the case of TB among children, this might be appropriate. In the case of influenza or coronavirus, it may not be appropriate. So we want to make sure that we address the issues for the circumstances we have. There's lots of information about cough etiquette and respiratory hygiene. What's this person doing? This is an indoor crowded waiting room in the wintertime, and this person is screening patients, looking for patients who have cough. Nowadays, they'd probably also be looking for fever. For the last of this column, let's take a look at administrative controls within the facility. Signage is very important. I don't know how many people can speak Russian that are online, but this says sputum collection room, and it gives different times for different departments. So the least infectious patients will be first, and the most infectious patients, and also MDR TB patients, will be last. This sign is a warning, basically telling the staff and people in the corridor that this is a high-risk zone if they need to wear respiratory protection. How about this? What kind of signage do you see here? I truly love this sign on the left. Again, this is related to TB, but it could be coronavirus with a slight modification. But if you have cough more than 20 days, don't even stop in the waiting room. Go directly to room 1. And some other public signage and information. How about other signage? These signs are obviously for what? For minimizing the spread of coronavirus. They talk about washing your hands. They talk about covering your nose and mouth when you sneeze. So we want to make sure we have simple messages. The one on the left, CDC was involved with, but personally, it's too many words. You get the same message with fewer words and bigger pictures on the right. So we have to think about messaging, not just staff, but people that go through the facility, including attendants, visitors, family members, and the patients. And I stole this graphic from the Stop TB Partnership website, and that's right now we can't separate TB and COVID-19. We have to deal with those two diseases together because there are many folks that are co-infected. With SARS, we found a lot of TB because there was enhanced tracking or surveillance. With COVID-19, we're finding more TB in some places because of the COVID-19 surveillance. And speaking of surveillance, what are a lot of places doing? A lot of places are checking temperature of the person coming in the building. Is that appropriate? Well, it helps identify people who have the disease and symptoms. It may not help identifying people that have the disease but are asymptomatic or no symptoms. And I started looking back historically. This is the first WHO guidelines for prevention of TB transmission in healthcare facilities from 1999. In 2007, they developed another document which is complementary to the first, but written more for the HIV care and treatment settings. And what's interesting is in there, They had 5 steps for patient management to prevent transmission of TB and HIV care and treatment settings. And they talk about, screening of patients, educating, separating, and these can be switched. It doesn't really matter. You provide the care that's needed, then you refer for TB. Well, in 2011, through the USAID-funded TB Care Project, there was a meeting in the Netherlands to develop the core components of an IPC program for TB. And what did they come up with? They came up with a FAST strategy: finding cases actively, separate, and treat effectively. And just recently, the African CDC came out with an effort or a group to accelerate COVID-19 testing. And they're trying to do a test, trace, and treat strategy. If you take a look at all 3 of these strategies, they're very similar. What do they want to do? They want to make sure they find the patients. They want to make sure that they can treat the patients. And this one, I like it because it clearly states we need to trace. We need to look at contacts so that we can find potentially other cases. And those contacts may have been the index case, or it may have been a case that was, or a person was infected by the one that was identified. So when we talk about administrative controls for workers, patients in the facility, what is common? Education is common. So we need to make sure that staff and people going through the facility are educated. It may be formal sit-down trainings. It may be informal health talks in a waiting area. It may be signage on the walls. This is one of my favorite ones. This is from Brazil. But what do you see in this graphic? What's saying, oh, I have to wear a respirator because of the picture. And it's a very simple message. It says you've got private quarters or private room. You need to wear a mask with a special filter. They really mean a respirator. And it talks about transporting patients with a surgical mask. And that way, when that patient is coughing, most of the droplets are contained within the respirator, or at least 50% are, for a very small cost. We talked about signage before. The one on the left is from MSF. And I really like it because you take a look at this. Where did your eyes go first? My eyes went to the fellow on the top left coughing. And you can see that with high velocity, he's sending particles out. The large particles will slowly settle. The small particles will go further than the photograph, and you're not going to see them, and they'll remain in the air for a long time. And that's what we suspect is happening with the coronavirus. Some of the small particles are still in the air for a long time. Some of the medium-sized particles might stay in the air for a period of time because it's not a perfectly still environment. There's turbulence, there's air moving up and down. And the graphic of this guy coughing not into his elbow, but trying to get to the upper sleeve so that when he or she coughs, it's hopefully most of it be caught in the sleeve. If you just do it on your bare elbow, you're going to get air going either above or below your elbow, and you're not catching or minimizing the spread of whatever you're coughing. Yes, you can use tissues. There's some advantages, disadvantages, and the ideal thing is really a surgical mask. But as I talked about last week with masks, that elbow, we need to make sure we talk about coughing into the cloth of your sleeve and not onto your skin. And lastly, we need to make sure that we have proper hygiene. After that, after touching your mask, after coughing into a tissue, after coughing into your elbow, we still need to think about hand hygiene. Now we're going to move on to the topic of environmental controls. What kinds of environmental controls do we have for the worker? Well, let's talk about environmental controls first. What should be thought of first, or what should we do first? Well, we have to understand risk because our environmental controls will not be the same throughout the whole facility. If we're talking about coronavirus and you have a large waiting area at a business, or you have a large dining area at a restaurant, we need to understand, well, what's the risk? What's the spacing between tables? What's the ventilation like? What kinds of people come in here? What hours are they? And we have to think about administrative controls, not jumping to ventilation or UV, but we need to make sure we have a good understanding of risk and that we've implemented as many of the administrative controls as possible. And what do we think of second? So for sure it's not going to be ventilation. It's not going to be UV. I'll give you a hint. Well, we have to understand how patients go through the facility.
Paul, we are not able to hear you. Paul, we are not able to hear you. I think we lost Paul in the connection there, but he is trying to dial back in. So we'll just wait. Kerry, there are some questions on the chat. While Paul is trying to join, should we discuss them?
Sure, let's do that.
Yeah. So there is a question there from Raiz Mazitov. Does normal speaking produce aerosol?
That's a good question. And I think Paul has, I guess that was in his presentation last week. There's a lot of labs around the world now are doing research and presentations on this with liquids so that you can see when people in a dark room, so you can see when people are talking what's coming out of their mouth because it lights up. So yes, aerosols can be produced through talking, definitely for TB, but also for COVID. There's a report published in the CDC morbidity, mortality weekly report from last month, I believe, but I think it was in March or April in Washington State in the United States, where there was a COVID outbreak also from in a church choir from singing. We know also that there's evidence that TB has been spread through singing in a church choir. So talking can aerosolize either TB or COVID and spread that way.
Okay, so there is one more question there from Nikes Dongol. How effective is the ultraviolet radiation from sun in killing the germs in the droplets or other natural elements, eliminating those droplets from the environment?
Excellent question. So, I see that our colleague Richard is also on the call and might be able to answer this as well. But when we think of UV, germicidal UV, we're thinking of a wavelength around 254 nanometer wavelength, which is different than what we get from the sun outside. I know that, or at least my president wants to support that sun will kill COVID. Sun itself doesn't necessarily inactivate TB because it's not the right wavelength. And there's some research going on now to see how effective the proper germicidal UV light is at killing COVID. Theoretically, it would kill COVID in the air. I don't know, Richard, if you're there, if you want to, while we wait for Paul, say anything more about that.
I think you're exactly right, Carrie, what you said. I think the main benefit of being outside would be natural ventilation and dilution. And those would be very effective against the COVID because it would dilute the concentration of the aerosol in the air. And there's no evidence at this point about sunlight having that kind of a benefit for deactivating a virus or TB. But the other environmental control that Paul will talk about is ventilation. So you have a lot of natural ventilation outside, and that's the best thing that you can have, as well as the social distancing. Looks like Paul is just about ready to come back.
Paul, can you hear us?
Yes, I can hear you fine. And if somebody could give my phone access, what I can do, if it happens again, then I can just talk on the phone while I'm rebooting the computer. But we were talking about taking a break about halfway through, and this is just under halfway. So let me just proceed.
Yeah.
Okay. So we talked about that the next step is understanding the flow of people through the facility. And again, that goes back to administrative controls. So we cannot separate administrative controls from environmental controls. So when we talk about environmental controls, it takes planning. So there's an expression here that we use, it's plan your work and work your plan. So we want to make sure that we have this group of people. Now we're talking administrative controls, which includes an epidemiologist, perhaps an architect, an engineer, people from, if it's a healthcare facility, people from the healthcare facility, management, people that buy things, to understand what is needed in order to implement environmental controls, and also what is needed for it to be sustainable, so that next year it's not broken and then you're in a worse situation than you were before. So when we talk about environmental controls, you often hear, oh, the worker has to be in a positive pressure room. So there we're talking about ventilation. So there's a door, this may be a little hard to see, but there's a door. I'm puffing smoke at the crack under the door, and it's blowing towards me. So the question for all of you is that good or not so good? Well, it depends is the answer. What side of the door am I? Or what's on the other side of the door? If the other side of the door is a corridor, and I'm in the nurse's station, and I want to protect myself from what might be airborne, this is not so good. If I'm in a patient room, that's in a patient room, and I see this, then that's good. Because what is being aerosolized in a patient room is not going to the corridor and going down the corridor to either other patient rooms or the staff. How much pressure differential or negative pressure would you have in the patient room that I'm standing in? It has ventilation, but with the door open, you have no control. So when we talk about ventilation at a future lecture, we're going to talk about how to optimize the situation of environmental controls, especially ventilation and UV. So let's take a look at this room. Instead of what I used before, I'm just using simple smoke. Is that good or not so good? Well, you're smart enough now to ask me, well, what's on the other side of the door? If what's on the other side of the door is a corridor, and what's on this side of the door is a laboratory, then this is perfectly fine. So when you do your assessment and you have ventilation, this is one of the things you want to check is which way is the air moving? The next thing for environmental controls, what do we need for the patient? Well, there we think about, and I talked about it a little bit with the smoke testing, but we need to talk about negative pressure or air not leaving that area. So here's a simple schematic of this is a patient room, and then we have a toilet, and then here we have a positive pressure anteroom. So with a positive pressure anteroom, the air goes into the corridor and it goes into the patient room. So the patient room is negative relative to the anteroom. The corridor is positive relative to the anteroom. And in this configuration, air from the patient will not go out into the corridor. So this is how we need to think about ventilation. It's not just, oh, we have so many cubic meters per hour or so many cubic feet per minute. We need to make sure what is the flow differential and what are the pressures in a room. What is this? It's not a telephone booth. It's a sputum collection booth. So there's a ventilator inside that pushes air outside, pulls air from here into the grill, across the patient to the fan, and the fan outside. And what do you see here on the left? An open window. So this is a situation where they have administrative policies in place so that when they're using the booth, they close the windows so that what is being exhausted doesn't come directly back into the facility. And what else do they have? Look, they have hand washing right next to the sputum collection area. So it's a very well-designed facility. There was a question about upper room UV. That we'll go into lots of detail on that in a future talk. But here's a fixture that's designed for relatively high ceilings. It keeps the upper part of the room with relatively high UV and the occupied space relatively low UV. Here's a different type of fixture. This is the top one was South Africa. This one's India. But you can see the blue light. The blue light is not the germicidal wavelength. Blue light is visible light. 254 nanometer, or the germicidal wavelength, is not visible. But it makes for neat pictures at night with the blue light. So you can see here's a fixture, there's a fixture, there's a fixture. And the top of the room has a lot of UV so that when organisms get up there, they'll get a lot of UV dose to inactivate them. And then we'll have mixing, and you'll hear more of that. Now now we're jumping to China. Here's a UV fixture, and you can see the blue light on the wall. Again, it's not the germicidal, but it's blue light that you can see. But the germicidal is up here, and the way you know that is actually to take a measurement. Then there's also the use of whole room UVGI, which is perfectly fine, except you can't have patients in the room, and you only do it for perhaps 3 times a day, a half an hour each. So you have a lot of bacteria in a room. The patients leave, it cuts it down to 0. Patients come back, it slowly builds up. So it's not a continuous cleaning. And then lastly, you may see whole room in an operating area, not necessarily while they're working, but after the terminal cleaning or the physical cleaning with disinfectants, they may use UV as a secondary way to disinfect surfaces. Last week, there was a question about room air cleaners. We're going to have a talk just about room air cleaners, but they come in all different flavors. And the reason I say flavors is some really are effective and some are, or most really, are not very effective. So we need to talk about clean air delivery rate, or what's the actual amount of air that goes in, how effective is it? Let's say it's 50% effective. So the clean air delivery rate would be 1/2 of what the actual airflow is. Or if it's 99% effective, then it's nearly the air in equals approximately the air out. If it's very ineffective, which many are, then it's not doing much in the room. Here's a modest size room air cleaner. Here's a healthcare worker and here's a patient. What do you see that's good and what do you see that's not so good in this picture? Well, you can't see where I'm standing taking the picture, but the window is open. There's some openings on the other side, so they have good cross ventilation. This air cleaner is taking air in here and sending it out these slots. So everybody's getting clean air delivered to them, but how does what he is coughing get into the air cleaner? That's what we have to think about with ventilation. That's what we have to think about with UV, is how do we get those aerosols to the control itself? And again, we'll talk about this in much detail. How about environmental controls for the facility? Well, doors, you may laugh, but doors are part of the facility infection control plan. You need doors to isolate ventilation. You need doors to isolate aerosols. You need doors for signage. You need doors for preventing unauthorized people into an area. This is a picture from Getty Images, but it's a airborne infection isolation room for coronavirus in China. So what do you see here? You see a door. I don't really see signage here, but there hopefully is signage somewhere around the sides. But they have a changing room, and then they go into the facility, come out of the facility, follow proper precautions with disposal of their PPE and hand washing, and then go on with the rest of their job. Here's a MDR TB ward, and because they do have ventilation, they keep all the doors closed. And if you were to puff smoke at the bottom of the doors, which way would the smoke go? It would go under the door and into the room. What is this? This is a nurse's station. How about something like this?
Kaç saat beni beklettin? Ben size dedim 2'de çıkalım. Yok. O 2:30'da çıktık biz onda. Değiştirmek zorunda kaldık.
Seving, I think your microphone, yeah, thank you.
Thank you. So here's a photograph from India, and I really like this. This is a small healthcare center, but they have their services on the inside with lots of natural ventilation, but all the staff are outside, all the patients are waiting outside. And what does that do? That provides separation. In the time of the COVID-19 pandemic, maybe the spacing isn't enough, but at least the patients have a place to go and not be overcrowded in a corridor or some very tight enclosed space. What do you see here? And we're still talking about environmental controls. You got big windows on the left, big windows on the right. You've got mixing fans. So it's a well-designed, naturally ventilated ward, which is relatively old because the new wards really aren't that way. The newer ones often have walls in the middle. So how much air is going to go through a wall? Not much. So something like this, you might have good air mixing, air dilution near the windows, but the patients over here have very little. And how about this one? I'm in a patient area. How much air goes through glass? Not very much. So if you're dealing with natural ventilation, we really need to make sure that the air can move across the room. And again, we'll spend an hour talking about natural ventilation in a future talk. What's common between administrative controls and environmental controls? Well, maintenance and operations. Let's give a couple examples. What are we doing here? Well, we're taking a look at a UV fixture, and we're taking some measurements, and we're trying to see, okay, first off, is it really putting out the germicidal wavelength? Because you can't see it, you can only measure it. And two, is it safe to actually be in the corridor? There's maintenance involved with UV. You need to clean the lamps regularly, replace them occasionally. If you have a louvered fixture, meaning you've got parallel plates to send the UV straight out instead of everywhere, you have to clean the baffles. And here again, this is a person taking a measurement relatively close to a fixture. How about ventilation? How many people think this ventilation system is good? Well, hopefully nobody raised their hand, because this is a facility that Grigory Volchenkov moved into. And the first thing he did in his assessment was say, hey, you know, our ventilation system is inoperable. And he developed a plan over a few years to revise everything. So he now has a very well-designed, properly working facility with ventilation. Let's talk about PPE. And Sahu, since we sort of had the break with the questions and answers, I was just going to continue on.
Yes, please continue.
Okay. So we're talking about personal protective equipment. What do we have? Well, for the worker, we always think about respirators. People who attended the webinar last week saw this photo, but it's important to make sure that people understand what respirator should they wear, when should they wear it, how should they wear it. So there needs to be a respiratory protection program. So in addition to having respirators, we need the administrative controls and policies so that people know how to use them properly, make sure that they fit. Here's this picture is from Brazil, but what is this person doing? He's doing a bronchoscopic procedure. He has a face mask, which helps with what? It helps with large droplets. He has a surgical mask on. What does that do? Well, it doesn't really help him by removing anything outside the mask, because it'll go right through the mask. But what it does do is it prevents what he might have, you know, if he has a cold or something, from being fully aerosolized and going into the patient's breathing zone. So when we take a look at an assessment, these are the kinds of things we want to look at. You know, is this appropriate? Should this person really be wearing an N95 respirator? And this is another graphic from last week, but I'm adding the next slide. But this is a CDC document that talks about preferred versus acceptable PPE. And the difference is only in the respiratory protection. This person is wearing an N95 respirator. This person is wearing a surgical mask. But the gowns and gloves and head covering, the face shield, it's all the same. So when you develop policies, in this case for the COVID-19 or coronavirus, then we want to make sure that people understand what is appropriate, what are the limitations. And what's on the bottom half of this graphic, which I think is great, is it talks about donning or putting on the gear, and also doffing, or how to take the gear off. So this is part of your program too. And the reason it's so important is there's suspicion, there's no way to prove it, but there's suspicion that some of the SARS transmission in Canada during the SARS outbreak was due to improper doffing or taking off the respiratory protection. Because they could take off the respiratory protection, but they might not have washed their hands immediately and may have touched mucous membrane or something else. What kind of PPE do we have for the patient? Well, surgical masks. And you'll see people wearing surgical masks. And we know, and we learned last week, that surgical masks, not all, but in general, provide about a 50% reduction in a study with TB. In that study, MDR TB patients, some XDR TB patients wore masks every other day. The air was sampled, and basically roughly a 50% reduction was found. In an artificial study in University of Cincinnati, in an aerosol chamber, they found about the same results. How to make a face mask, there are many, many different ways, but you know, basically any kind of fabric that you can't see through is probably helpful. And if you have too thick of a fabric, some people talk about putting vacuum cleaner bags inside of a mask. Well, what does that do? Well, you're not really going to be able to breathe in and out through a vacuum cleaner bag. So if you cough, yes, the large particles will go straight out and be caught on the inside fabric, but small particles are still going to go around the mask. So when we talk about PPE, especially respiratory protection, we need a respiratory protection program or administrative control that we talk about with those policies and practices. One of the things I do in trainings is I make sure everybody knows how to put on a respirator. We don't make them wear it for the whole course, but we make them wear it for maybe 10 minutes or so that they understand how to put it on properly. This person is looking at the mask saying, I'm not sure I want to put it on. But anyway, it's really important to make sure people put it on properly and adjust it. And then fit testing. Here's fit testing from 3 continents. And they're doing qualitative fit testing. This person's happy doing it. This one doesn't look so happy. But the idea is, does that respirator actually fit the person who's wearing it? And what is common for the worker between administrative controls, environmental controls, and PPE? Well, it's education or education and training. So we want to make sure that those people understand what they need to do and how they need to do it. And one thing we emphasize is actually after your assessment, start out with a simple table. Don't list 200 things that you need to do, but list maybe 10 things. What kinds of administrative controls should you change or implement? What environmental controls do you want to add or change? And the same thing for PPE or respiratory protection. And it won't fit all on one page, but give a little description about it. How would you go about it? When? It might not be today. Some administrative controls could be tomorrow. Some may take a longer time. What kinds of short-term and long-term budgets do you need? And for environmental controls, we need to make sure, can we afford the electricity for it? Can we afford the maintenance of filters, replacement of UV lights and whatnot? And then lastly, what kinds of obstacles might you face? So infection prevention control is really a continuous process. Once we get started, we plan, we implement, we evaluate, we engage, and we assess. Then we go around and around and around. And if you're this spiral looks like it's going into the screen. If you're an optimist, it looks like it's coming out. So what we want to do is we want to think positively and say, yes, we can implement and we can continually evaluate and change and improve. So I want you to just remember that the hierarchy of infection prevention control is somewhat complex, but it doesn't mean it's complex to implement. It might be complex to explain what we really want to do, and that's part of the purpose of these webinars. We need to understand, administrative controls, and I only talked about these topics a few minutes, but it's to get everybody thinking about what all do we need to know. So we have our administrative controls, environmental controls, and PPE. And it might be the same or different for the worker, the patient, and for the facility. So what we need is we really need a package of measures. And we need to plan for sustainability. And lastly, this presentation was made possible by support of Stop TB Partnership. So I thank Luchika, Sahu, and everybody else at Stop TB. And the funding for this was through the U.S. Agency for International Development, and I also thank them. On the ETTI website, you'll see 3 documents that were written, and they're in the process of being updated to include certain things that might be unique to COVID-19. But there's one on respiratory protection, one on respirator fit testing, and one on UVGI, or GUV, ultraviolet germicidal irradiation. Also on that website soon, we'll be posting a link to these webinars, and we'll have a schedule of the webinars. I've got 3 slides here, and Sahu has a copy of the presentation, which I think is going to be posted soon, if it hasn't been already. But I want everybody to take a look at this list of future webinars. Next week, we plan to do something on administrative controls. And there are many topics within administrative controls. We can't just talk about administrative controls in one section. For environmental controls, there's a long list of things. Between natural ventilation, mechanical ventilation, UV, room air cleaners, and there are different aspects of them. So again, here's a long list for environmental controls. For PPE, I put a line through the first one because that's the lecture we did last week, but you can always look at it again, or if there's certain topics within respiratory protection that we did not cover in enough detail, we'd be happy to modify it and do another presentation there. So what I request is everybody look at these 3 slides and help us prioritize what should be the next topic or topics. Luchika asked us to talk about respiratory protection first, because that's a very common question Stop TB Partnership gets. It's a very common question that we as ETTI get, and I get personally. So we want to be flexible. We want to be reactive to your needs. So again, please take a look at these 3 slides and help us develop a webinar series that's going to meet your needs as quickly as possible. Then lastly, this is sort of my summary of life. And that's that what we want to do is we want to work hard, we want to play hard, we want to promote good public health, we want to be safe and enjoy life. And enjoy the simple things in life. This was my old golden retriever, and when she was a puppy, she would spend an hour playing with this sprinkler. So it's a good way to get her teeth brushed and whatnot, but we just need to enjoy life. And then here's another thing. This is a parade we were in, and there's Dolly. She was queen of the parade. So anyway, I thank you very much, and Sahu, if you'd like to take over and moderate, I'd be happy to answer questions, and we have some other folks from ETTI online, and I'm sure they would be happy to answer some as well.
Thank you, Paul. Thank you. That was very nice, a complete overview of all the different aspects of airborne infection control. So we have Paul as well as we have Carrie here, Richard here. So if people on the webinar want to ask questions, this is the time. Either you can raise your hand there if you know how to do that, or you can write in the chat box that you want to speak, or you can type your question in the chat box. That would be great. So I already see that there are some questions on the chat box. One of them from the time that we left is, I'm trying to go back into the questions and looking at, so we did the question on ultraviolet, and then we have, there is a question on, there's a long question from Fernando Sanchez. If you are on the call, do you want to speak it out? Or ask if you're there.
Hi, hello.
Yes, please go ahead.
Hi, Paul. I would like to address some. This is more a comment with a question together. So we know that environment control or some administrative measures is quite complex to understand how it could be engaged with airborne disease to create a sense of biosafety or knowledge to improve many other conditions to getting a health and decent work. So my question is, inside of some steps, now with video, inside in some steps to consider which measure to
Fernando,
conduct
your voice is breaking.
inside facilities or their like schools or religions facilities. Do you think it is it's kind of steps? The first ones, the like a level 1 or to make it more touchable, handle. It's like, do you know what is exactly the rate, the good rate of ventilation? I think people has some difficulty to understand what is, or you see a window open, so it is necessary to adequate inside our metro cubic in this area. So do you think you apply some measurements using monitor CO2 is relevant or not relevant? Is kind of first approach. And then if you have some values like inside of quality of air for health air, we consider 1000 ppm for CO2. And we have some historical relating with disease spreading by airborne like TB, when is considered 600 at the minimal level of getting beneficial of dilute the virus or particulate matters from the ambient, the environment, sorry. Consider this, the next one can be easier to getting UV light or even HEPA filter to be implemented. I would like to you comment some of these points, please.
Okay, thank you, Fernando. Quite often, you know, people ask good questions, and this is a phenomenal question. And the reason I say that is it gives me a chance to talk about the complexity of airborne infection prevention and control. You may be in, and you talk about a church. A lot of churches have are very large volume, or you take a look at the ratio of volume to square footage or square meters, you know, it's relatively large. So you have a lot of natural dilution in a large room. But if you have people sitting, you know, half a meter apart, maybe 30 centimeters apart, you could have 1,000 air changes per hour in that room, but you're not going to stop the spread from person to person. And it doesn't matter if we're talking about TB or coronavirus or anything else. The first thing we have to think about administratively is separation. Not necessarily separation in different rooms, but we need to decompress facilities, decompress waiting rooms, so that we don't have the person-to-person spread. And then secondarily, you would consider the ventilation. If you have a let's say a room with sort of a normal ceiling and it's crowded, then I think yes, you could use CO2 as a surrogate for the potential for transmission. But you know, if you decompress it, which should be the #1 priority for all diseases, then you know you won't have that problem. What can you do? Well, you know, again, #1 is administratively, you know, can you decompress? #2, for environmental controls, you know, what do you need? You know, if you're in a temperate climate where you can use natural ventilation and have cross ventilation, meaning from one side of the room to the other, because air will blow maybe left to right for a minute and right to left for a minute, so it allows a free flow of air. If you just have one window in a room, then just like that one photograph I showed you earlier, then you're going to have a lot of air exchange near the window, but you may not have it far from the window. So if you have a situation where you're in a temperate climate, you can't have good cross ventilation, but you do have electricity. Some places don't have stable electricity. Then you might consider UV. But again, if you're in a crowded room, optimal ventilation will not help very much. So I'm sorry I can't give you a definitive answer, but it really comes down to your infection control committee discussing these items and seeing, okay, can we decompress? Can we modify the building for cross ventilation? Do we need actual CO2 monitors? And let's say you do go above 1,000 parts per million. You might set a limit a little bit higher than that, but let's say you do go above 1,000 parts per million. What are you going to do? Are you send people outside to wait on the sidewalk? Or are you just going to say, okay, we have too much crowding? And when we take a look at room air cleaners, I could spend a day just talking about room air cleaners, but there are a few that are very good, and a bunch of them, you're wasting your time, wasting your electricity. So going back to the Infection Control and Prevention Committee, they're the ones that really should be reviewing and hopefully coming out with some recommendations. Thank you.
Thank you, Paul. So we have Daisy, your hand is up. Daisy Thomas, please. Daisy, if you're speaking, you need to unmute yourself and speak.
Yes, I'm speaking.
Yes, go ahead.
Like, yeah, because of the droplet infection, should we educate the patients regarding the disinfection of their toothbrushes also? Should be, because the patients, those who are having with these droplet infections, like coronavirus or with the tuberculosis, should we educate? Hello, I'm audible?
Yes. I hear you.
So,
I hear you loud and clear.
So should we educate our patients that they should be disinfecting their toothbrushes also?
Well, I mean, that's a question that I've only been asked one other time, and the answer is it depends. Okay, if that person is the only one to use the toothbrush, and you rinse it well afterwards, that's probably good enough. You wouldn't want to have like let's say a glass with your toothbrush, your spouse's toothbrush, and three of your children's all in the same location, because you could have cross contamination. But you can essentially isolate your personal items, and then
yes,
you would be fine.
Okay, thank you.
So we have some on the chat, and two of them I'm grouping together. From Seving was a comment there which said MIT has a research that cough particles fly much higher. That was known before. That probably, much more than it was known before, up to 10 meters. And then Peter Oviti also writing, what is the science behind 1.5 or 2 meter distance when droplets go much further? So Paul, these two questions.
Okay, no, those are great questions. Carrie, do you want to start?
No, you can go ahead.
Okay. This is my opinion. The WHO came out with 1 meter separation. CDC came out with 2 meter separation. There are some studies years ago where they took a look at aerosols being emitted from patients. They put petri dishes on the floor and tried to grow organisms. And what they found was, if you have, at least 3 feet or 1 meter spacing, you might get a few, and then at 2 meter spacing, you didn't get any. But it didn't take into account small droplets and some medium-sized droplets. So if you have air currents or air movement in the room, the very small particles, and that's what MIT is showing, and a lot of the models, computational fluid dynamic models show also, is that yes, you can get these medium-sized particles to go, several meters, and the very small particles can go much further than that. And with just a little bit of breeze, let's say you have a 0.5 meter per second, these particles can move further. So instead of a normal trajectory, and you think of it, I'm using my hands, you can't see it, I'm sorry, but it goes out and then slowly descends to the ground. Well, if you have air moving in that same direction, or the person has a very strong cough and forces it in that direction, well, it's not going to have the same trajectory. It'll go out further before it descends and hits the ground. So, you know, is 1 to 2 meter spacing appropriate? I think it's probably appropriate for most situations, and especially if someone is wearing a mask, that will limit the velocity of the air coming out. And for sure, 1 to 2 meters, even 1 meter, I think would be adequate spacing. Thank you.
Thank you, Paul. There is one more question on the chat from Karuna Sagli. Several TB hospitals have centralized air conditioners. How does this affect infection control?
Okay, and it depends on what is meant by centralized air conditioners. If the air goes from, let's say, 3 patient rooms to the ventilator and then gets recirculated to those same 3 patients, then, you know, it's not ideal, but generally we'll say, okay, that's an acceptable method because you're not transmitting organisms to other parts of the facility. If it is, you know, one whole floor, which includes staff areas, visiting areas, patient areas, goes to a ventilation system and goes back to those same areas, then no, that's not appropriate unless you have some high level of filtration or UV to collect or inactivate the microorganisms. So the answer for that one is also it depends on you know, where the air comes from and where the air goes. So again, if it goes to the same area, it's not ideal, but you know, I would say it's acceptable. But if it goes from many areas and back to many areas, then no. Thank you.
Thank you. So we have Empower Shankar India. You want to speak? Can you unmute yourself and speak, please?
Yes. Can you hear me, please?
Yes, go ahead.
Already I have asked this question. Is there any data available? How many asthmatic patients is affected through C19? Whether it is available globally or it's specific to India? I would like to know. Thank you.
Okay, I'm sorry, I missed the last part.
I would like to know how many people, how many asthmatic people affected by C19. Is there any data available throughout the globe or it is specific to India? I would like to know. Thank you.
Okay, no, that's a great question, and I'm not aware of any data. I don't know if anybody else from ETTI is, but you're welcome to chime in.
I am also not aware of any data on asthma and COVID. However, we are trying to collect data on TB and COVID. We are in discussion with some countries and researchers there. It will be great to have some data there. There is a study published from study available in the domain in China and another one from Italy. Information in the form of a PowerPoint from South Africa that gives you some information on TB and COVID overlap. We are aware that some people in India are looking at it and maybe in other countries as well looking at it. It will be very good to get some information on the overlap between TB and COVID because both affect the lung and we need to know what is the impact of COVID on TB in terms of treatment outcomes, longer term impact and so on. Asthma and COVID is also a very good question. I haven't looked at it, but there must be something in the literature. If anybody else is aware of it, if you can put it in the chat box, that will be helpful for everyone.
We can also, this is Richard from ETTI.
Yes, Richard, please go ahead.
From ETTI. I think there has been some literature on comorbidities with COVID mortality. And some of that, I haven't looked at it deeply, but we can take a look at it. And if we find anything, look to the ETTI newsletter. We publish a quarterly newsletter, and we'll be coming out with one towards the end of this month, beginning of next month. And if we find any follow-up information on this, we will list it in our literature review.
Thank you. I see Predag, is that a comment or no, that's a question. According to some articles, UVC has an impact only within a radius of 2 meters. What is the rationality of installing the UV lights in the ceiling? Also, some articles claim that it is necessary to have exposure for 15 minutes to the UVC to have effective disinfection. Is it true? Any comments?
Okay, this is also a great question because there's so many different fixtures. There's so many different fixtures and types of UVC lamps and whatnot out there that it's very confusing to me. And when we take a look, you know, there's some papers out there that say the 254 causes cancer and cataracts, and we know for sure that based on lots and lots of data that that's not true. As far as the UV only being effective within a radius of 2 meters, well, what you might find is some fixtures with low output. That's true. With a well-designed fixture, there are several around the world. I would say it's a minority of the UV fixtures are sold, but there's several good facility fixtures around. But they put out a lot. They may put out, you know, say a half to a little over 1 milliwatt of UV energy, or I'm sorry, watts of UV energy. And what does that mean? That means that you have a fixture that instead of just putting out a tiny bit, you have UV, in this case of a louvered fixture, going maybe all the way to the other wall, which could be, say, minimum of 8 meters, 10 meters away. So as you get further and further from the lamp, you may find that it gets a little bit lower, then it increases in intensity, and then as you get further away, it decreases and decreases. But a well-designed fixture can easily be effective in a 3x5 to a 5x5 meter room. And then if you have a bigger room, you just need more fixtures. But the thing that's not mentioned in this question is, for UV to be effective, it needs to be part of a system. And again, we'll give a full talk on UV. But what I mean by system is, if I'm in the patient room sitting beside the patient and the patient's coughing, I'm so close that, you know, UV ventilation, room air cleaners probably won't be effective. But if he or she is wearing a mask, I'm wearing a respirator, and we want to just reduce what's aerosolized in the room further, then what we need is the UV system. That means we have to be mixing the air. The air from the occupied space has to go up into that top part of the room where it's irradiated and be there long enough to inactivate it. So we need some air mixing. The exposure time of 15 minutes is probably, I don't know which article you're referencing, but it's probably one of the references for irradiating masks and respirators. where what they want to do there is have enough dose of UV, which is exposure times time, or irradiance times time, to make sure that they inactivate everything on the surfaces, not the inside, but on the surfaces of the respirator. Just a minute.
There is a question from Dilip Patil. Can you please give your comments on newer technologies like cold plasma for spread of TB?
No, that's a interesting topic, because that leads me back to the room air cleaners. Cold plasma is an effective technology, but what we need to do is make sure we have select the proper cold technology equipment. And there's one company that sells cold plasma units in which air goes in, clean air comes out. Some are relatively low flow. There's one that's relatively high flow. So if you want to use something like that or any air cleaner technology that's effective, if you want to use a room air cleaner in a room, we need to understand what's the clean air delivery rate. What's the airflow rate relative to the size of the room, so we can estimate the air changes per hour. So if you have a itty bitty cold plasma unit, it may not do much for a room. You have a larger one that has sufficient cubic meters per hour, cubic feet per minute airflow rate, then it has potential. But just like with ventilation and UV, we need air mixing. Because if we put a room air cleaner in the corner and it only cleans the air in the corner, that's not going to help us. We want to make sure that the air cleaner is located, the air cleaner is designed to work in harmony with the room. And in some cases, you might need to add a mixing fan if the room air cleaner doesn't come out at a high enough velocity to force mixing of air in the room. Thank you.
Thank you. There seems to be another question from Dilip. I think we will take this as the last one. I don't see anybody else there with a question. The question is for testing TB airborne infection control, can surrogate M. smegmatis be a good indicator? Same with COVID, can MS2 bacteriophage be a surrogate indicator? Dilip, you may have to explain this, but what I understand is you want, instead of testing Mycobacterium tuberculosis, you want to test Mycobacterium smegmatis for airborne infection control. And for COVID, you are asking whether you can use MS2 bacteriophage.
Yeah, I think I understand the question. What he's talking about is, if we wanted to evaluate in a artificial environment where we can aerosolize either this Mycobacterium smegmatis, again, it's a bacterium, or MS2 bacteriophage, which is often used as a simulant for different viruses, would it be appropriate? Now, depending on the technology of the air cleaning, if it's UV, then we need to understand what's the susceptibility of M. smegmatis and the MS2 bacteriophage to UV relative to M. tuberculosis and coronavirus, respectively. If we take a look at the literature, and I don't remember M. smegmatis for UV, but I think it might be slightly more susceptible than TB. So I would just need to look up the susceptibility of that organism to UV. And the same thing with the MS2 bacteriophage. There are a number of people doing work with bacteriophage as a simulant for coronavirus in evaluating controls. If you're talking about an air cleaner that either destroys or filters organisms, then it doesn't matter. The M. smegmatis will be about the same size as M. tuberculosis. The MS2 bacteriophage will be about the same size as coronavirus. But we have to understand with any artificial environment, how realistic is it? With some studies, they put simulated sputum or simulated saliva in the aerosol, so you end up with slightly larger particles. So most technologies that filter or destroy will be more effective. Something like UV would be less effective. So it really depends on the technology, and what he's talking about is this cold plasma technology, which is something that destroys the organisms. But I'm not endorsing his products or anything, but they also have their large unit, which has a high efficiency filter as well as the cold technology. And something like that, I think, would with the appropriate airflow rate and the appropriate size room, would be perfectly fine. Thank you.
Thank you. So we come to the end of this webinar. Carrie, do you want to say a few words at the end?
Yes, thank you, Sahu, and thank you to Paul for presenting on the overview of airborne infection control. And based on the questions from the participants, I think that we have some, hopefully our future presentations will answer a lot of those questions as we go into the more detail under each of the different headings that Paul highlighted today. As Paul said, next week we'll focus on all the various parts of administrative controls. And when we get to environmental controls, I'm imagining that we'll be doing different administrative controls across several weeks, because there's a lot, and those are areas where we always seem to get a lot of questions. So we look forward to continuing these webinars and hope that you continue to join us for them. And as we've said, on our website under the Stop TB Partnership Working Group, and I know that the website has been posted in the chat box, we have more materials there, so please feel free to visit that. And the presentations will be available after the fact on our website, so you can listen in later. I know some people said that they had problems with hearing the presentation today, so hopefully you'll be able to hear it on the recording. So thank you all again and again. Thank you very much to Stop TB for your support in allowing us to do this.
Thank you, and thank you to Carrie, Paul, and Richard. Thanks to everybody who joined, and please join our subsequent sessions, which will be focused on few things. And if you can give us feedback on what you would like to listen, that will help us in developing this further. Every week there will be something there, so we would like to have your feedback on it. The recordings are all available on the website. Kadira put here the link, and as we progress, we will do that every week. So thank you all. Stay safe, stay healthy. Good evening, good afternoon, good morning, depending on where you are. Thank you all. Bye.
Bye-bye. Thank you.
All right, thank you.
Thank you.
Thanks.
Thank you.
Carrie, did you leave?
Bye. Thank you.
Bye-bye.